Hi everyone, my name is Kevin Bambury and I welcome you to another episode of Oncology Spotlight. Thank you for tuning in. I'm joined by my co-host, Ono Carroll.
Hello everyone.
And today's guest is Dr. Akash Maniam, who is a medical oncologist from Portsmouth in the UK. Thanks for joining us, Akash.
Thanks for having me. Pleasure to be here.
Just to kick things off, could you briefly introduce yourself and share your background?
Yeah, sure. Would love to. So, as you said, I'm a medical oncologist in Portsmouth in the UK. Professionally, I focus a lot on breast cancer and urological cancers. But beyond that, I have a wider interest in health equity and access. So I'd say that's really what my biggest passion is. So whatever I try to do in my practice involves trying to harmonize everything that we do into a wider, more global context to see how we can bring these amazing innovations that are happening every day to as many people as possible.
Excellent.
Very good. And Akash, what inspired you to specialize in oncology, and how has your journey been from the Caribbean to the UK so far?
Yeah, well, to be honest, I always wanted to do oncology since I was in high school. It just always was what I wanted to do. I've always been impressed by how quickly things advance in the field, because in medical oncology, I think the biggest draw is that apart from the wonderful patient relationships you get, the long-term follow-up you get, it's really interesting that you always feel out of your depth in terms of your knowledge. You just have to learn constantly just to try and stay afloat. And every time you feel like you're getting there, something new comes and you have to put it in context. And the challenge is really interesting. So that's really why I wanted to do it. I think it integrates the art of medicine with the science better than anything else. In terms of the journey, well, I suppose it's more complicated because I mean, having been born and raised in the Caribbean, I did move to the UK for many years, and then I went back, and then I came back again. So I suppose I've had several journeys to and from, and it's always been interesting, because where I'm from, say Trinidad and Tobago, it was a British colony. So there are lots of similarities between the two. Obviously, the systems were formed during British rule. And so there are lots of similarities between the systems, between the way education is delivered. But obviously, culturally, it's completely different, and access is completely different. So it's been interesting seeing what we have here, what we don't have there, and trying to find ways to bridge that gap.
Could you kind of compare the systems between the UK and what you see in the Caribbean at the moment? Like, what are the differences?
Well, most of it is very similar in terms of the hierarchical structure and the way that things are devolved at a trust level. They're very similar. The biggest differences, I would say, are one, the formality of it. So where let's say lower and middle income countries tend to have bigger challenges is with robust guidelines and frameworks for practice, policies, and systems of audit and service improvement, which is what the UK does very well, and where we tend to struggle a lot more. So things are less audited, and therefore, practice can vary quite a lot from place to place. On the flip side, that also means that innovation is a bit easier because you don't have as much bureaucracy that sometimes can get in the way of it. So it is often easier to go from, licensing and funding to implementation. The time frame can be shorter. But the second difference, and really the biggest difference, is the access. This is not unique to Trinidad. It's not unique to the Caribbean. Even within the Caribbean, there's such heterogeneity because of income disparities. But it's really access to therapeutics, access to diagnostics, access to clinical trials, and access to specialist support. Because if I don't know something, there are several colleagues in the same field, even within my own hospital, who I can always meet with and discuss cases with. But in places like that, you might be the only one with a specific focus in that area, and getting help easily is not straightforward. They're not unique challenges, but yeah, there are definitely big differences between what we have here and what exists in most of the world.
Yeah. So, like for example, if you in a institution in the Caribbean, like there might not necessarily be other oncologists. Is that the scenario, or
I mean,
would it be?
For example, if we look at the Caribbean as a whole, in some of the territories, some of the smaller island states, they may not have any oncologists at all, and they may have to get help from larger islands or larger states nearby, just to provide that sort of support. Some of them may just have one, and so there is that heterogeneity. And if we're looking at the whole Caribbean, you have very small islands with 40,000, 50,000 people, but you also have very large territories like Guyana, which is larger than the UK, but has 800,000 people, and they're spread all over the Amazon, etc. And trying to bridge that sort of gap and provide care to places that might need a few hours by helicopter to reach. The challenges are quite wide if we look at the Caribbean as a whole. So, getting cancer care to those people, it is a challenge. There's a lot of work being done, but the challenges are very different to what we face here.
Yeah. And are there lessons, like, is there anything from the Caribbean that you think could be adapted in the UK and vice versa? Like, what would you like to see happen?
Definitely. So if we go from here to the Caribbean, I think the structure is great. The structure here is great. Obviously, the system has its challenges, but I do appreciate the levels of governance and oversight that go into these things. And there's a level of robustness that comes with it that's more independent from, let's say, politics or partisan influence, etc. They're things that at least can outlast government changes, which isn't the case in many parts of the world, where things can change when the government changes. These structures are stable and more sustainable, and that really means that patients don't feel the brunt of any drastic changes in focus. I think that structure would be the most important thing. Secondly, the clinical trials, if we could somehow improve our access to clinical trials, that's where the innovations come, and often that's where they come for free to patients. That is a massive thing if we can bring that to them. On the flip side, in the Caribbean, I think that because in many places the resources are more scarce, the innovation and the drive to collaborate and implement things is much stronger. And that's definitely something that is not unique to the UK, but many more advanced economies with legacy systems like this, there can be a lot more inertia and sometimes more resistance to change. Whereas when you have countries that don't have access, they're often just much more practical, much more willing to say, well, this is what we have, this is what we can afford. Let's just see how we can, bring more stakeholders to the table, whether that's the pharmaceutical companies, whether it's academia, whether it's global bodies like the Pan American Health Organization or the World Health Organization, etc. It's like, how can we bring access? So we cast a wider net because we just need to try and get more access. And that, I think that collaborative approach definitely, we could bring some of that here.
Excellent. Very good. And just moving on, Akash, just your editorial, Refugees Have Cancer Too, addresses the challenges refugees face in accessing cancer care. Can you share your inspiration behind it?
Yeah, well, so my co-author on that paper and I both have a lot of personal experience with that. We have family members, etc., who have been refugees and have been displaced by war. And I suppose when you're interested in access and health equity, I think the plight of refugees brings that most sharply into focus. They have the most acute and urgent needs for things that we often take for granted. And I suppose that's really what we wanted to look into, to combine our personal experience, personal interest, and try and scale it up to the more established concepts of global health that we know about and that we're discussing here. So that's really where it came from.
Very good.
Could you elaborate on the key issues highlighted in the article?
Yeah. So I think this article obviously looked very specifically at the current wars and conflicts going on, for example, Russia's war in Ukraine, the war in Gaza, or the war in Sudan, for example, which were the main ones discussed here. But it really just wanted to highlight some of the core concepts for providing care to arguably the most vulnerable of patient groups, and highlighting the sorts of specific challenges they would face. So, for example, you look at legal and administrative barriers that they may face. So it's obviously heterogeneous, but often refugees might lack legal status or documentation, or they may be separately enshrined within a different country's law. So maybe they can stay, but they can't access care. Or if they can access care, they can't access specialist care. So they can only get emergency care, but not necessarily secondary care like cancer care. Secondly, look at financial constraints. Obviously, many refugees don't have economic means and the ability to afford care. So even if they can't access it through the system in a public healthcare system, they can't purchase their care either. They can't purchase the medications, or they don't have insurance that can cover them for those sorts of things. We also looked at the infrastructural challenges, because many of these refugees are not just externally displaced, but internally displaced as well. And if you look at, say, Ukraine, when the war started in 2014, many of them were internally displaced from the east and south to other places. But the systems didn't necessarily have the capacity to absorb that change. Then after 2022 and even more moved, you can't just build hospitals overnight or absorb that capacity suddenly when you have millions of people placing extra strain on the resources. So that was one thing, obviously, the infrastructure and the healthcare personnel to deal with it. Then we also wanted to highlight the cultural and linguistic barriers they have. And again, I think Ukraine is the perfect example, because within Europe, each state has, different linguistic identity. And for many Ukrainians, you go even just to countries nearby, say Poland, etc., the languages are different, and they can't just learn this overnight, and healthcare providers might not be able to provide care in a way that they understand. And for something like cancer, which is so personal, it's even more difficult to translate the fears and the way people feel, which goes beyond language, but just something much more primal to us. And so they can feel quite marginalized. Finally, we really just wanted to look at the social and psychological challenges that they have, because even if everything there were taken care of, the trauma from being a displaced person, the social isolation, the lack of support, knowing that you might have family in a country affected by war, maybe family who's been killed or traumatized in some way. And so even if they are in a place of physical safety, they're still completely isolated. And on top of a cancer diagnosis and the disruption to their treatment journey, because some of them might have started treatment and then had months without treatment because of the physical translocation they've had. And yeah, the psychological torment is quite high. So what we really wanted to bring attention to is just those core challenges that people face, regardless of where they're from. These are challenges that really all of them would face.
Yeah.
Very good.
And are there strategies outlined to kind of deal with these challenges, or is that left open to discussion?
I think we wanted to highlight it for discussion more than anything else, because it's something that is relatively poorly discussed. And when it is discussed, unfortunately, this is a topic that's often quite politicized and is subject to a lot of inflammatory rhetoric, which we wanted to try and take out of it, just to say, well, whatever someone's personal view on it is, these are real issues real people are having, and we need to find a way through it without, demonizing them or their struggle. But there are things that people can do, but it is going to be challenging. So, for example, if we look at the legal and administrative hurdles we discussed before, that will be a national conversation. Each country will have to decide on what policy they can afford, what policy they can implement to integrate these patients and give them care. If that's in Europe, then obviously it has to go up to the EU and to see what funding mechanisms there are and ways that they can at least provide emergency relief because obviously different European countries have different economic accessibilities, and they don't want to strain their own systems for their own populations to accommodate refugees. There has to be a way to integrate both of them, but that takes time. If we look at financial constraints, are there any supranational funding mechanisms, say from the UN, from the WHO? Are there any mechanisms for accessing emergency support to provide these patients with care? Healthcare infrastructure, very difficult. It just takes so much time to build that capacity and staff that capacity. But if it's a protracted war, or, like for example, say in Syria, where it lasted for over a decade, then you just have to plan, and you have to invest in that sort of infrastructure and find ways to fund them. For cultural and language barriers, I think it's much more straightforward. With the advent of technology now, it's much easier to get a translator via video call, via translation apps, even Google Translate. Many patients would just use it, and while it is a bit crude, it's so much better than it was 10 years ago, where it would have been almost impossible. That's something that's quite easy to do, and there are lots of volunteer organizations around where you can access that sort of help. For the social challenges and psychological support, that I think that's the biggest challenge more than anything. Because to be honest, it's hard to deal with a trauma like war when it's still ongoing and you don't know when it's going to end, how it's going to end, and what you might be able to return to. And that uncertainty, on top of the uncertainty of, say, cancer diagnosis and recurrence or progression, is a very difficult thing to address, because you don't want to give patients false hope or diminish the disorientation they feel. But again, there are volunteer organizations, so increasing awareness of access to support, it would definitely help, because many of these patients who come to places like the UK, etc., they have no idea what's available. Many of these organizations might only be known in English-speaking communities, for example, and they may not have any clue how to access these sorts of things. So at least as a system, we can find them and signpost people to them in their own languages, for example.
Are these organizations country-based, like are they international, or would it be country by country?
Both. There are some which are exclusively virtual, which at least, transcend boundaries. But many of them are not just national, but grassroots. So, for example, even within Portsmouth, you'll have a Ukrainian community, for example, and each city any city in the UK that has any significant population of Ukrainian refugees would usually have that sort of community. You look at countries, say, like Ireland and Germany, Sweden, which have had very long histories of acceptance towards refugees and of generally a very positive culture towards bringing people across who are vulnerable and helping them. They do tend to have lots of organizations, just voluntary organizations by ordinary civilians, to help integrate people. So there are lots around. There are lots of good people who put themselves out there to try and help.
Yeah. So is there any organization you'd like to mention, and we could link to it in the show notes if that was helpful, for our listeners?
So one I think that is quite good, at least for Ukrainian refugees, is an organization called TeleHelp UA, or TeleHelp Ukraine, which is based in the US, but it's entirely virtual, and it provides free consultations to any patient with a medical condition or mental health condition who wants to get more advice with people who speak their languages. So it's a way of helping people in a very straightforward way. I think they're a very good organization. That's just one.
Okay, excellent. TeleHelp. Okay, that's good to know.
We'll link to that. Great. No problem. And just to mention your co-author, Dr. Mona Hassan, as well. Who's involved in the editorial. We know her well. And it's great to see this being highlighted as well. Like these are topics that are kind of not easily seen or discussed, I suppose, especially in the oncology community. And it's great to see that that they're being brought to the forefront. So,
I completely agree. Mona is exceptional.
She is. So just moving on, can you discuss any mentors or experiences that significantly influenced your path?
Yeah, for sure. I don't think anyone can get to any point without a mentor, without someone helping them, or many people helping along the way. I think for me, at least in Trinidad, I had I guess I still have a mentor, Nick Kavi Capildeo, who really opened up so many opportunities for me and opened up the world of oncology to me. And, I still keep in touch with him. We still work together and discuss cases when we can. But yeah, he's extremely sharp. And I think having someone like that at home at a time when there weren't that many oncologists around really showed me what oncology could be in the Caribbean and where the gaps are and how to address them. So yeah, I would say he would be my main mentor, but there are lots of other people who've helped along the way.
Of course.
Can you tell us a little bit about your role at Portsmouth and, the initiatives that you're involved in and how you're trying to enhance patient care at present?
Yeah, I suppose within Portsmouth, it's more regulated. So I tend to meet quite a lot with different stakeholders, whether it's, say, like yourselves, who bring innovation directly into people's clinic practices and daily lives, or whether it's pharmaceutical companies to discuss compassionate access programs or free of charge programs or new clinical trials, emerging clinical trials that we might want to bring our center onto. I would say that within Portsmouth, you're always careful. Within the NHS, you have to do things in a certain way, and you don't want to overstep, because both as practicing clinicians and obviously as industry representatives, there are guidelines for practice on both sides. So within that framework, you try and discuss what you can. More broadly, we would tend to speak to colleagues across the country and across the world to see what trials they have, what their practice has been like, and share practice guidelines and ideas for implementation to see what we can do. But I'd say in terms of access, most of what I would do is based in the Caribbean rather than here, because access is very good here in general. It's just, mostly procedural work here to try and overcome, say, bureaucratic hurdles to trying to get better access.
Very good. Okay. And given your experience, what are some of the innovative approaches or policies that could help bridge the healthcare gap for underserved populations, especially in oncology?
Well, I think you guys at Oncoassist do quite a lot to make that simpler. And I think that would be the first thing to discuss. I think given where we are in the world, it's an easy win to leverage the power of data, of digital platforms, of AI, whatever terminology we want to use. It is where we are. It's not just the future, but it is the easiest thing for us to do, because most places in the world can access an app. Most places nowadays can access the internet, and it seems like the simplest thing. If you look at your own app and the tools that we obviously develop, the frailty tools, etc., anyone can use that. That is completely independent of economic status and, what therapeutics you have available. Anyone can use these simple tools to assess patients. So integrating digital platforms into our care definitely is one of those things we can use to bridge the gap. And being flexible. COVID made that much easier and more mainstream. Idea of remote working, hybrid working, and I don't want us to go back to how it was before. Where now, if you're someone in the Caribbean, if you're in a place where you don't have access, for example, physically, it's very difficult to reach somewhere, you can't afford to get somewhere in an island where there isn't ready oncology care, you can meet via video, you can meet with oncologists around the world and still get advice, guidance, and support. And I think that's critical. We can use them to develop health records, electronic health records in many parts of the world that don't. And we can also use things like artificial intelligence to analyze pathology, to analyze radiology, to try and standardize things where you might not have access to those, technologies. So I think that would be the first one. The second, I think, is it's something you take for granted in say North America or Western Europe, etc., where you have MDTs or tumor boards regularly. Across tumor sites, it's very easy for us to access that expertise on a weekly basis. But many parts of the world don't have that. They don't have MDTs, they don't have tumor boards. That is definitely something that improves patient care. And given that we have access to digital platforms, to me, it should be something we could implement, where if they don't have all the specialists in a given hospital, maybe they could link nationally, regionally, internationally to access those specialists, because giving advice is easy. If you have people on the ground who can present the data and they've met the patients, then at least you can get that advice from someone else. If you don't have access to it, we're very privileged to have that here, but I think that makes a huge difference. I know we were talking earlier about NCCN Harmonized guidelines, and I think that's another thing where it's a big step in the right direction, because even here, the NCCN guidelines have access to things that we in the UK wouldn't be able to have access to. Having some sort of standardized care pathway, standardized guideline in systems like that is much more meaningful. Because if you're in a country that doesn't have access to most of these therapeutics, then reading the NCCN guidelines is useless, because it just really reflects what you can provide to someone. But the harmonized guidelines at least are a much better effort to bridge that gap and say, well, don't feel bad about providing care that is, not what is provided in North America. This is what you can provide, and this is the best version of that care you can provide. So you should judge yourself on that basis, rather than to a standard you just cannot physically meet. And if things change, access improves, you can edit the guidelines to incorporate new therapeutics, just like we do in the UK, just like it's done in North America anyway. Final two things for that would be, one, looking at systemic barriers to collaboration. We really just need to find ways to incentivize collaboration. There are lots of places where they have consultancy, where you would pay a fee for a service, which sounds good in principle, but often ends up disincentivizing teamwork and collaboration, because, instead you want to focus on value-based reimbursement. So you say, well, we will fund this if we have actual value add to the system. And in concert with that would be reducing the regulatory processes, streamlining them to make that easier to integrate that sort of collaboration, because that's really what patients need. They need consensus. With cancer, there are often multiple decisions you can reasonably make, and having consensus and good access to it makes things much safer. And finally, as with anything, you just have to improve access to patient involvement and caregiver involvement. Patients are the heart of it. So these same tools that we have, that we use to assess their frailty or assess toxicity, etc., you can easily use these tools and customize them for patients, so they can access their care plans, they can communicate with their healthcare teams, they can track their own progress. It makes them feel like a bigger part of their journey and gives them more power, and it helps to reduce some of the opacity in some healthcare systems around the world where it's still very paternalistic. The physician will say, this is what you need to do, this is what you have to accept. And those decisions are shrouded in mystery. Right? If everything is just in the open, you could say, well, okay, this is why we've done what we've done. These are the facts about your case. This is your diagnosis, your stage, your treatment plan. So if they want to Google that or take it to someone else for a second opinion, you can stand by your decision, and they at least know what they're asking about. Just getting them more involved, I think, is something that's not universally done. It's much better done here in the UK, for example, with the NHS apps and these things.
It's starting to happen more. I think people are more attuned to it, especially with everything going online.
Yeah. With regards to AI, how do you see AI helping in oncology, or do you see any potential opportunities there?
Lots. I think I think the bigger challenge with AI is destigmatizing it and regulating it. and we need both to happen at the same time. It's arguably the most important breakthrough in our generation. And while it's amazing and powerful, of course, you need regulation to set boundaries on what we should aim for. But the power is there. If we look at oncology specifically, we've already discussed telemedicine to some extent, but it's made telemedicine so much easier. Now there are just AI-enabled telemedicine platforms that triage and allow access without the human resource. That needs to be regulated, of course, but it is still providing people with access to something that they physically wouldn't have been able to access otherwise, and streamlines this remote consultation paradigm. On our side, on the healthcare provider side, it definitely can streamline our tasks. So scheduling, requesting scans, requesting blood tests, even interpreting them, etc. There's so much that it can do to take away a lot of the admin time for clinicians and free clinicians up to see patients and spend more time addressing their concerns, which is what patients want and what we want to do as well. If we look at diagnosis, I think it's already here. It's already happening. There are already, convolutional neural networks looking at imaging and analyzing, say, mammograms, CT scans, MRIs with extremely sharp sensitivity, in some cases exceeding what human radiologists can achieve, which makes sense because obviously computers can do a lot more than most of us can do in terms of, say, calculations, etc. So it makes sense that AI can achieve this. They can find cancers that we physically can't see. Same for pathology. They have more concordance in many ways, especially in very difficult, rare subtypes or subtypes of DCIS or things that are very difficult in general to classify. Hand in hand with that, you'll also have genetic and molecular profiling. So AI can really help with precision oncology in terms of analyzing next generation sequencing to try and predict which therapies are more likely to benefit patients. So, for example, if we look at immunotherapy, which has revolutionized cancer care, there have been studies looking at machine learning models that predict responses to immunotherapy by analyzing the tumor mutational burden, for example. That makes our job much more precise, which is what we want. We don't just, when we talk about access, you don't just mean having the drug, you mean getting the drug to the right people who really need it and not treating everyone the same. So if you can predict which patients are going to benefit, you'll want them to get it, and those who don't, you want to spare them the toxicity of the drug. So that personalized medicine really would help. And in oncology, again, if you look at things like radiotherapy planning can be optimized with artificial intelligence. So minimizing how much radiation exposure healthy tissue will experience and maximizing it to the areas you really want. I think those are really the main areas where it can help streamline things from diagnosis to treatment.
Yeah.
But we have to look at the ethics, we have to look at regulation, and all of these tools that people develop must be validated in a real world clinical setting on the population you want it to use. Because many people say AI is great, but they might not understand that AI is only as good as the data it's trained on and the questions you're asking of it. And if you're in the Caribbean and you're using AI that's been tested on, say, Western European populations, that really is inaccurate for the population you would have at home. You'd want those models to train on people in Trinidad, St. Lucia, etc., so that you can reproduce those results. So it is very exciting. There's a lot of power, but the regulation is key, I think.
Cautious optimism.
Cautious optimism,
Yeah. It's a good way of putting that.
Yeah, very good. Just moving on. So just finally, what advice would you offer medical professionals or students entering the field of oncology?
Well, honestly, more than anything else, I would say don't look at oncology as a traditional medical career. I think when we're considering medicine as a whole, but definitely oncology, don't just look at it as what it is now or what it used to be. Understand that you can have a very satisfying career in oncology by doing a wide array of things. You can be a clinical practitioner, you can do clinical trials, and you could focus on global health and policy. You could work in the pharmaceutical industry. You could work in health tech, start up some company and bring an AI solution onto the market. You could do multiple of those at the same time while still, helping people. I think keeping that flexibility and that agility is the most important thing, understanding that you can actually leverage your qualifications to do a lot of good, not just where you are, but across the world. So the biggest advantage is the flexibility and the collaboration. So if you're going to go into oncology, just never lose sight of it and keep your focus too narrow.
Okay,
very good. So you're involved with IUCS in Portsmouth 2025. It's been going on the last 2 years. Can you just give a bit of information about the event and what's the focus?
Yeah, so, IUCS, so the International Urology Cancer Summit. I suppose it's our, it's our baby. We're very proud of it. We're very proud of it in Portsmouth, and it's gone from an idea to a forum where you have experts from around the world coming to discuss the latest practice-changing innovations in urological cancer, so prostate, kidney, bladder, etc. And it's just become so much bigger now. We have people from all over the world coming to attending online. It will be in Portsmouth in person on the 4th and 5th of September. It will be available online. As it was the last 2 years, it is free to sign up, whether online or in person. So there's really no reason not to get involved and join. Even if you can't attend, you can still sign up, and the recordings will be available to you for free after the event. So yeah, why not? Just come down to Portsmouth if you want, but otherwise just join online for free anyway.
Yeah, the work that you and Dr. Giuseppe Van have put in has been fantastic, and it's been a really enjoyable event for the last 2 years. So yeah, I advise anyone to register or go to the event on the 2 days. So yeah.
Yeah, Dr. Bana has been amazing. I cannot give him enough credit for it. But yes.
No, he's been fantastic. Yeah.
Thanks very much for joining us today, Akash. We really appreciate you taking the time to talk with us.
Anytime. Always a pleasure.
And thank you to everyone who's listened or watched this episode. You can catch us on the next one.
Thank you.